Good evening, ladies and gentlemen, and welcome to tonight's Wound Care Today Facebook Live, our first of the year. Before we start, just a massive thank you to all of you for joining us in such huge numbers. Your commitment to education and your vocation is utterly inspiring, so thank you so much. Tonight's event, in partnership with IQ Medical, is called Can You Handle the Pressure? The importance of pressure care equipment selection. And our two awesome speakers who are here with me now are Nikki Griffiths and Joy Tickle. Good evening, both.
Hi, everyone.
How are you both?
Hi, thank you.
Good. Thank you so much for joining us. Ladies and gentlemen, as you can see, Joy's, I think, in the office, Nikki's at home. So if we have any technology problems, please bear with us, and I promise you we'll get it sorted as soon as possible. The event's going to be available on our Facebook page forever, free of charge, but we will also put it up on our website that is woundcare-today.com, where you can not only watch the event, share it with your colleagues, but also download the slides at any time you like. The link for your certificate of attendance, which counts towards your revalidation portfolio, will be made available towards the end of tonight's event. We'll put up a slide, and also it appears in the comment bar. I think, as both Nikki and Joy will agree, the more engaged you are with tonight's event, the better it is for them and for the event in general. So please feel free to leave comments and to ask as many questions as you think is relevant. And I promise you we'll endeavour to answer as many of them as possible towards the end of tonight's event. Before we start, just a massive thank you to the team at IQ Medical. Without your commitment to independent education, these events simply could not or would not happen. So a massive thank you from me and the whole team. So without further ado, it gives me great pleasure to hand you over to tonight's first speaker. Over to you, Joy.
Hi, thank you, Ed, and good evening, everybody. And it's my pleasure to be talking with Nikki tonight about the pressures around selecting pressure relieving equipment. I'm going to begin by setting some of the learning objectives, and they are to understand the role of equipment in both the prevention and, of course, the management of pressure ulcers, but also to understand the importance of support surface selection, and that's what we're going to concentrate a lot on this evening. One of the objectives is, of course, to ensure that appropriate and timely intervention following a robust clinical risk assessment, and then to have the knowledge and the confidence to ensure a seamless transfer of care for your patients where necessary. So the right equipment, the right time, and the right place. And we're all aware of this really importance around pressure ulcer prevention and management. We have a plethora of evidence around correct pressure ulcer prevention and management, and lots of fantastic local, national, and international campaigns. And you don't need me to go into detail about all of those wonderful campaigns. We have the EPUOP, your own local campaigns, React to Red, National Wound Care Strategy campaign. So we have a lot of real robust evidence. But what it made me think a little bit about is, despite all this fantastic work and all of the evidence, staff is still reporting to me about confusion still around selecting the correct equipment for pressure relief. And I can relate to that in practice as well. So why is that? Why is that in 2021 we're still having those dilemmas? And what are the consequences of that incorrect decision making? Let's begin with talking a little bit about that equipment assessment and selection, but whose responsibility? We know that a pressure relieving support surface is any device or equipment that can reduce pressure damage. We know that. In some areas of practice, the majority of times, healthcare clinicians are involved in that assessment of the patient, assessment of the environment, and that selection. And that can involve nurses, podiatrists, occupational therapists, physios, OTs. I can't mention everybody, but that wider MDT team. But I still hear in practice, and I've witnessed in practice, where referrals are made to a nurse to undertake a clinical risk assessment for the patient regarding pressure ulcer prevention, and it's the nurse to implement the equipment. And that nurse may have no input whatsoever with those patients' healthcare needs, but it's assumed it's a nurse's responsibility. And I did you know, that I currently witness that. And it's not, it's all healthcare clinicians or providers, it's everyone's responsibility to have the knowledge and the skills, not just about assessment, but choosing the correct equipment for the patient. Of course, there's other departments involved with equipment selection through purchasing and other areas such as the equipment management teams or EBME, procurement services or community equipment services. So you've got to be knowledgeable, I say knowledgeable, aware of what services or services even, Metallic Live, are available for you to obtain that equipment. You've got to be aware of that. And the reason I talk about that, when I worked in Shropshire, we had really good clinical working relationships with the community equipment services and the equipment advisors. And we were often asked for our clinical input when it came to looking at purchasing or renting pressure relieving equipment. And I think that should happen. It should be that full MDT approach of selection, not just from a point of view of procurement. But unfortunately, that doesn't happen everywhere. And I think that then can cause challenges in itself. I think patients, carers and families, of course, are not responsible for assessing their own equipment or selecting it, but they certainly need to be responsible for the maintenance of that equipment, to know how to use it safely and appropriately, and for me as well to be involved in the choice of that equipment. And I found that when we have involved patients with regards to making the choice of equipment, I think it does enhance concordance with that equipment as well. But when I've been spoken to staff and looked at articles and evidence around equipment, pressure relieving equipment, I wanted to know what were those challenges when it came to equipment selection. And frequently it was that poor understanding or knowledge of the different types. So we all understood the importance of equipment and pressure relief, but it was the different types that we didn't always clearly understand. And I think that goes without saying. And I think we have to have that knowledge of different types of support surface that we can put in place for our patients. So you need that understanding knowledge. And clinicians and healthcare providers were saying that that was still lacking, was that clear understanding. That lack of understanding or reduced knowledge will lead to incorrect equipment assessment, and then we're going to put the wrong equipment in for our patients. And that goes without saying the consequences of what may happen there. But what we also must remember is the patient's journey, the different equipment in different care settings. I saw a patient recently who's in an acute hospital ward on a high specification mattress, who's being transferred home into a nursing home, who don't have that high specification mattress. They have different types of equipment, or that patient might go into their own home. So we need to ensure that patient's journey is seamless, that it's the right equipment based on the patient's risk assessment in the right care environment. And we need to all be talking to the clinicians in that area about the right equipment for the patient and making it available for them. But that can be a problem. Or no equipment. I've seen patients assessed at high risk, and certainly there's been no equipment in place, and the consequences I will talk to you later about. For me as well, finally, another challenge that I find in practice and that I've had mentioned to me is that equipment's implemented, but it's not reviewed. And it's assumed that, well, we put the equipment in place now, we no longer have any responsibility. From the minute we assess our patients and implement pressure relieving equipment, there's a need for that regular reassessment. Our responsibility starts then, and we need to ensure that that equipment is reassessed to see that it still meets the needs of the patient, that it still meets the needs of the environment, and that it's working effectively. And to me, reassessment of equipment comes hand in hand with reassessment of the patient who's at risk. But the consequences in practice, and I hope you don't see this, but the consequences in practice to me for the patient, that increased risk of skin damage or potential pressure ulcer development. And you can see the image on your screen of that significant category of pressure ulcer with the devitalized tissue. Existing pressure ulcers can deteriorate if we make the incorrect decision. So they can deteriorate from let's say, a category 1 into a 2 or a 3 and a 4. And I hope that doesn't happen, but it does happen. For me, the most important factor is it causes significant pain and suffering to that patient. You know, you can imagine if this was a relative, a family member, and I'm sure you've seen patients with this category of pressure ulcer, and the pain, debilitation, the suffering, the embarrassment, because they're normally in areas, can be in areas of the body that it's embarrassing to expose, and leads to significant social isolation and depression. And don't just think the older patient, please. Think about the younger patients, the patients who unfortunately develop these category pressure ulcers and significant skin damage. You know, those patients that work who now are going to have to spend more time resting or on bed rest, and the impact on their lives. Unfortunately, it can also lead to hospital admission due to infection or deterioration of the wounds or pressure ulcer. And unfortunately, I've seen where it has led to sepsis and death. Consequences of those incorrect decisions to the organisation or your healthcare providers, I don't think you need me to say we will see a significant increase, certainly an increase in the risk of pressure ulcer prevalence. That increase then comes along with increasing your time, clinicians' time, whether it's nursing, whether it's physiotherapy to keep the patient as mobile as possible whilst in bed or when going from bed to chair. Everybody's time will be increased. The carers' time will be increased. They will need increased social care as well as healthcare, increased resources and equipment. And let's not forget, this is patient harm, and we will see significant increase in the harm of the patients resulting in harm. That will mean as well for organisations and for you, as maybe some of you as individuals, we'll see an increase in the amount of root cause analysis we have to undertake, investigations, possible legal consequences. And if any of you have ever been involved with any RCAs or report writing and legal issues, it's extremely stressful, causes a great deal of anxiety and a high amount of time. We must also remember we are accountable. All of us are accountable for our actions or lack of actions as well. And you know that it will have a massive impact on your accountability. And as I've already mentioned, increased hospital admissions or delayed hospital transfers if the equipment is not available, and that can happen also. So the patients in a hospital environment when actually medically they don't need to be. So what are the important factors to consider when selecting a support service? I'm going to start and talk about some of them, and then Nikki's going to carry on and talk more specific around the patient factors. So my first slide talks about correct selection is dependent on the patient risk assessment. I'm sure you're all aware of the tools that you use in your care establishment regarding assessing the patient's risk. And Nikki's going to go in more detail specifically to the patient. But those sort of risk factors are looking at their mobility, nutrition, hydration. But of course, we must also undertake that holistic assessment of the patient. So underlying comorbidities or medications that may increase the risk of skin damage. And that may be conditions such as diabetes or medications such as long-term steroid therapy or immunosuppressive drugs. But what we also need to assess is the environment. When we're looking at equipment, is the environment suitable, or what equipment will be more suitable for the environment where the patient is cared for, particularly important in the patient's own home, looking at space and safety and the factors around even simple things that if the patient's living in an area, a rural area where there may be risk of regular power cuts, that will influence your choice of equipment as well, or the type of equipment. What I must add there is also that pressure relieving equipment needs to be considered for a 24-hour pressure relief. Not just equipment, but the care. But if we're concentrating on equipment this evening, that 24-hour pressure relief, the equipment needs to be in place, whether it's the patient on the bed, the patient sitting in a chair, the patient in a wheelchair. It's got to follow the patient journey. And what I want to talk about there is also your patients who travel. Okay, looking at pressure relief in their vehicles, certainly looking at pressure relief in ambulances, and in outpatient areas. I mean, I've known patients to sit in nobody's fault, but because of waiting times, not so much during COVID, but before COVID, waiting in a waiting area for an hour, 2 hours if they're waiting for transport. Now, they may have wonderful pressure relieving equipment at home on their seat and on their bed, but they're sitting for 2 to 3 hours on a hard surface. So we've got to think of the 24-hour pressure relief and the whole of the patient's journey. So other factors that we need to be aware of, certainly be aware of when we're selecting pressure relieving equipment and knowing what is available, is how it is available. How accessible is it? How soon can you is that equipment available to you? And I've put here about financial resources. Now, I'm not saying you have to be aware of the total finance resources of how that equipment is purchased, or is it loaned, or is it on rental agreement. But you need to be aware of it, because that will influence how your equipment will be delivered to your patients. It will be also a consideration of how soon can that equipment be replaced if it's damaged or if it becomes faulty. And as all healthcare clinicians, we need to be aware of that in case that there is a problem. Do you have an equipment store? Do you have a library? Do you have satellite stores? I know in the community where I used to work, we had really good satellite stores, so that in times where we have new assessments for patients, we don't know straight away if that patient's at risk. So we need that equipment ready, or certainly some equipment readily available. Know how you can retrieve that. Know how you can source it very, very quickly for your patients as well. And certainly around the cleaning and maintenance of that equipment, that to me is everybody's responsibility, including the patients and the carers and the family. This equipment is expensive, and we need to take responsibility for looking after that. So think about all those considerations. How will it be cleaned? How can it be cleaned? And how it's decontaminated as well. Other things to consider is returning the equipment. So not just having the equipment delivered, but how is it returned? And I still see mounds and mounds of equipment that is still not in use any longer, but still in a patient's home or a care environment that haven't been returned. It's not just a cost issue. That vital equipment could be used for other patients who are at risk. So how is that equipment returned, and whose responsibility is it? And again, it's a case of not saying, if you see equipment, you may not have implemented that equipment, but if it's no longer being used and the equipment belongs to your healthcare providers, arrange to get it collected or returned. It's still everybody's responsibility in the organisation. What's the lifespan or the replacement of that equipment? Because that's important if organisations are purchasing their own equipment, because we need to ensure that the equipment in the satellite stores or the stores were aware of the lifespan and the maintenance of that as well. So I won't go into all of those details because time won't allow, but please make sure you're aware of that process, about that equipment availability process as well. And not all support services provide the same level of prevention. We must really totally understand that. So staff, patients, carers, we always must follow the manufacturer's guidance and organisation. So your organisational guidance as well. And you will have guidelines on your equipment selection, maintenance, and all the factors I've talked about as well. And my final slide talks about appropriate and evidence-based pathways and guidelines. And what I'm trying to say is the pathways and guidance, they don't take away your professional assessment and your professional judgment, but they can assist you in selecting the correct equipment. Make that selection process a lot more simpler, reduce the time it takes, and making sure then we do get the right equipment for the right patient in the right care environment. So if you haven't got pathways and guidance in your workplace, I'm a big believer, don't reinvent the wheel. We can share with you some really, really good examples, and do ask for, other colleagues as well. And what we must ensure is that, and I know you might think, why is that on the slide? Ensure there is an appropriate, well-fitted cover for the mattress or seat cushion. The number of times I've seen inappropriate covers over seat cushions, mattress seats, heel protectors, towels, layers of towels placed on, incontinence sheets. And the reason being, I do understand it, some of our patients are afraid of soiling or marking the mattress or the sheet. And we have to reassure them that, you know, that we can clean them. And if we're using the coverings, the covers are the appropriate covers for the mattress or the seat cushion. Because again, I've seen ill-fitted sheets and cushion covers applied where they crease and they rock on. They again, of course, there's shear and friction when the patient's moving, or even significant pressure damage from just creasing within that cover. So I myself felt that was really important to put that when considering the support surface. And wherever, you know, support surfaces are really important. That's why we're talking about it, but they shouldn't be used in isolation. Please don't use them in isolation. Let's encourage, of course, keeping our patients moving if possible, or repositioning again if possible. And of course, the mobility and repositioning will be dependent on the patient's ability and the risk factors. But you know, support surfaces are not used in isolation. It's the 24-hour care for that patient as well. And finally, you know, think about the patient choice. We do want to encourage mobility, as I've said, and choice, but I frequently hear, I don't like that equipment because I feel hot, you know, that mattress. I'll give you some examples, because I feel hot, or I just don't feel comfortable. If we can give our patients a choice, and certainly they need to be involved in that decision making about their equipment, I really have seen how patients then are happy to concord with that equipment. But if there's a reason they're not concording with the equipment, take a step back, have that conversation with the patient and find out what it is they don't like about that equipment, because I'm sure there is always an alternative or a way that we can resolve that. So I'm now going to hand back over to Nikki now, thank you. And Nikki's going to continue to talk about those important factors to consider, but also talk about the patient in more detail and about give a fantastic example of a patient journey. Thank you. I'll hand over to Nikki.
Thank you, Joy, for sharing your experiences. Joy has focused on the organisational requirements around equipment. I will now focus on individual patient assessment and discuss some of my experiences within my organisation regarding equipment and the pathways that we use. In order for patients to have support surfaces that meet their individual needs, several factors need to be considered. These include their weight, height, and body shape. If their weight exceeds the safe working load for the equipment, they may need equipment that is designed for the heavier patient. Equipment also often has a minimum weight level, and people sometimes forget that, and that can actually influence the comfort of the patient. As Joy's already mentioned, the patient's pressure, ulcer, risk assessment, and whether they have existing pressure damage and the severity of this, and whether the surface is for therapeutic use or prevention, are other factors that need to be considered. Also, mobility levels, whether they can reposition themselves or need assistance, can be considered or need to be considered. Concordance is also a key consideration, and I know Joy has touched on this, but sometimes patients may not be willing to have an air surface and may be concerned about their comfort. So it's important to consider if they are happy to be on an alternating surface, and has the reasoning behind the need for this been explained. Some patients can find alternating surfaces cause a feeling of seasickness, and therefore alternative equipment may be required. You may have your own pathway or equipment selection flowchart in your care setting, but I have included an example of the one we use in my organisation, which we use to assist staff in making the correct equipment selection based on some of the criteria I have discussed. Of course, equipment is not just limited to mattresses, but appropriate cushions and other aids such as leg troughs, heels, and offloading devices also will need to be considered. Once the correct equipment has been selected, it is really important to ensure that it is set up correctly and that it is continuously monitored whilst in use. In my organisation, I often walk onto a clinical area and hear the equipment alarming, which means although a patient may well be on a correctly chosen piece of equipment, it might not be working properly, and the patient could still develop pressure damage. Quite often mattresses are deflated, and if there's a full air mattress there, the patient could end up just lying on a hard bed base. We have in my organisation daily equipment checks where staff are required to document that the equipment is working correctly. The support surface needs to be secured to the movable parts of the bed base, otherwise the mattress can rip and tear, and also the mattress can slip off the actual bed base. Equipment should not be used if it's dirty or damaged. And safety elements should also involve making sure that the cables are not a trip hazard and that the pumps are on the end of the beds and not underneath, because if you lower the bed down, they can be crushed from the bed lowering onto them, and that causes cracks in the case where fluid can ingress. These are a couple of images of safety issues. Nurses being resourceful with their sticky tape, and the misuse of a leg trough sandwiched underneath an air mattress. I've also seen full mattress replacement systems on top of a foam mattress, which mimics the Princess and the Pea scenario. And I'm sure many of you and Joy could cite similar examples of inappropriate use. Therefore, that equipment safety is just so important. This brings me nicely onto staff education and competency. I always say that a bed, mattress and chair are the most essential pieces of equipment to effectively look after a patient in hospital and indeed sometimes at home. But how many staff could say they have been trained on how to effectively and safely use all the key functions and benefits of the equipment? It's therefore really important to consider who is responsible for delivering education and training in your care setting or organisation, and who does this remit fall under. It might be tissue viability, medical engineering, equipment store, manual handling, infection control, or a combination of all of these teams. It is also important to decide what platforms are used for training and how staff can take ownership of their knowledge and skills. In my organisation, we use case studies and get staff to risk assess the patients and decide which equipment they need. We also set up mock crime scenes so staff can spot the potential problems with the way in which we have set the equipment up incorrectly, which helps them to identify with how they need to set it up correctly. We have an intranet page that contains information about the available equipment and training videos, some of which have been provided by the companies that can be accessed. We also expect staff to complete self-verification forms so that they take some ownership and accountability for using the essential pieces of equipment. We have these self-verification forms for air mattresses, cushions and bed bases. Staff are expected to watch the videos, then print the forms and sign to say they are competent to use them safely. They should keep a copy and provide one to their managers, and it is expected that they do an update every 3 years or more frequently if we change the types of equipment we are using. As previously mentioned, as well as an appropriate support surface in bed, if the patient is sitting out, then a suitable chair and/or cushion needs to be considered. When sitting out, different pressure points are at risk of damage compared to those at risk when lying in bed. It is in a fine line balancing rehabilitation requirements and the risk of pressure damage. It is important to have a multidisciplinary approach to this and get occupational therapists and physiotherapists involved, particularly if there are sitting balance concerns. If pressure damage is present, then the clinicians need to determine whether it is appropriate for the patient to sit out, and if so, how long for. NICE actually recommends that sitting out should be limited to no more than 2 hours if pressure damage is present on the patient. When sitting out, a good seated position is really important and can be promoted by ensuring that the chair is the right height and depth for the patient. Patients should be encouraged to keep their feet flat on the floor and use arm rests if available. The seat should be wide enough to allow the patient to move themselves within the chair, and repositioning should be encouraged. This could be sitting and standing or rocking from side to side. Chairs may have inbuilt pressure reducing properties, or pressure relieving cushions may need to be added depending on risk assessment and any pressure damage. And as Joy mentioned previously, other surfaces that can affect the interface pressures should be discouraged. We often see procedure pads underneath patients or hoist slings that have been left behind the patient, and these need to be removed. I would like to share with you my experience of using the cushions and mattresses that we have in our organisation. The pressure relieving cushion that we use is the Cursor 2. This relieves pressure by one cell inflating whilst the next is deflated. It has proved really comfortable for the patients and is easy to use and set up. It has a 200 kilogram weight limit and an anti-slip mat and securing straps to ensure that it stays firmly in place, which prevents patients from slipping off the chair. We have also introduced the Star 2 dynamic mattress. This again is very simple and easy to set up. The key benefit we have found is that it provides a high level of comfort for the patient and is really quiet with a very low noise level. So this reduces patient disturbance, especially at night. It has proven to be very reliable, and our medical engineering department are delighted that they rarely have to fix these mattresses. It is effective in preventing and managing injuries with robust clinical evidence supporting its use. The company offer excellent support and are always on hand to deliver education and training and provide us with advice if needed. The key features of this mattress are the dynamic and continuous low pressure modes and maximum inflation for clinical procedures. It has 6 straps which individually secure it to the bed frame, has CPR for rapid deflation in an emergency, and has a transport mode, which means it stays inflated for 48 hours. Inflates in less than 20 minutes and has visual and audible alarms. It's really easy to keep clean and maintain and comes with a 3-year warranty. What I would say is that we need to remember to reevaluate care and equipment provision as the patient's condition changes and the pressure ulcer may improve. We need to consider step down prior to discharge and equipment provision at home. And I've got an example of that patient journey on the next slide. So Joy and I wanted to share with you a typical example of a current patient journey and how there are different points within this where equipment can make a significant difference. So a married patient with an acute illness collapses at home, lies on the floor for several days, hours, and is brought by ambulance on a stretcher to hospital, where he is diagnosed as having breathing difficulties and test positive for COVID-19. There is a pressure on hospital beds, so he has a long wait in ED on a trolley. When the nurses finally come to move him to a ward bed, they notice he's developed pressure damage and he's on a foam mattress. On the ward, the nurses obtain an air mattress and regularly commence repositioning. His breathing improves, but he has poor mobility and develops a grade 4 pressure ulcer. We then look to discharge planning as his condition improves, but this is obviously far more complicated than when he first came into hospital, as he now requires an adjustable bed and an air mattress. And this has massive impact on his family life and quality of life, as you can imagine. And I'm sure you've all come across similar scenarios. So in summary, the selection of pressure relieving equipment needs to be based on that holistic patient assessment and consider all the factors that we have discussed. The equipment must be used in conjunction with and not be a replacement for a 24-hour pressure relieving plan. Education and training is essential for all those using the equipment, and the effectiveness of the equipment needs to be regularly reassessed. Thank you all for listening, and I will now hand you back to Ed.
Thank you so much, Nikki. Thank you so much, Joy. Thank you so much, ladies and gentlemen, for bearing with us. This session will be repeated throughout the evening and through tomorrow, and will be available on our website. So if you did miss any bits in the middle, please watch later tonight, tomorrow, or go to our website. Guys, there's some awesome value-added support from IQ Medical on their website. There should be links now on the screen and in the comments bars, so please get involved. Go to their sites. There's some fantastic stuff there, so have a look. Guys, just a brilliant event. Ladies and gentlemen out there, thank you so much for your comments and questions. I asked you guys to get engaged, and I'm not sure I've ever seen so many questions and comments, so thank you so much. So, Nikki, Joy, are you okay if I crack on with the questions?
Yeah.
Okay, so question number 1, which is from Annaline. Nikki, I'll ask you this one. How do we get around noisy air mattresses being the reason patients decline the equipment when they have been assessed to having need for this?
Well, as I mentioned, the IQ Medical one is that when we did our project evaluations, that was one of the key things that came out, that mattress was particularly quiet. I think it's around looking at the age of the equipment and also the positioning of the pump, because sometimes if you put a pump on a rattly bed base, that can cause vibrations and problems there. So it's a combination of factors, really. But I do think that was one of the real selling points of us switching to the IQ Medical mattress.
Fantastic, thank you. So question number 2, Joy, for you. This is from Lorraine Jones. Good evening, Lorraine. Do you think staff overprescribe the specification of equipment in community and fear stepping down?
Can you repeat that, Ed, please? Sorry, I had a little bit of an issue with my hearing then.
All right, so do you think staff overprescribe the specification of equipment in community and fear stepping down?
Yes, I do. So, hi, Lorraine. I think we tend to definitely overprescribe high specification equipment because we think put the patient on the most high spec mattress or seat cushion, whatever we're talking about, because that'll reduce their risk. And I think and we are frightened. We don't want our patients to have any harm. We don't want them to develop skin damage. But it is reiterating that their choice of equipment has to be around their risk, and their level of risk. And if we put all of our patients on, and we do overprescribe high specification equipment, it means then those patients that actually do require it, those patients at high risk, and I have seen it where we have had, particularly in some community settings, where that equipment's not available because it's already being used on a patient that actually doesn't require it. I think the other part of Lorraine's question is about stepping up and stepping down, and I know Nikki mentioned this, and I do find that in some areas we don't do that because we don't reassess the equipment. And in Shropshire, we did have a project where we had equipment reassessment staff, and they would go purposely to reassess, particularly pressure relieving equipment. And it worked. It was invaluable because they didn't just reassess the patient, they reassessed the equipment, but the number of patients we could step down, or in some instances, required increased high specification mattresses. I think that pathway has to be built in with that reassessment. But very good question for Lorraine, and yes, it does happen.
Thank you, Joy. So the next question from Alison, and this is for both of you, I think. Some areas discharge patients once healed, but still have pressure ulcer equipment in place. It's stated there is not enough resources to perform equipment checks, pressure ulcer assessment. I disagree with this. Do you, Joy and Nikki? Nikki, do you want to start?
Well, I would agree that, there's not enough resources available really to go around to everybody, but it's like Joy mentioned, it's about that risk assessment, it's about appropriate discharge planning. Often in hospital they don't step patients down before they're discharged, so they try and discharge them on the high level equipment, and like Joy said, they want everybody to be on the best equipment they can possibly be because there is a bit of a fear factor out there, but it's about getting what is the right equipment for that right patient at the right time. Joy, do you want to add?
I think I do agree, but I think it still takes me back to my slide that says your responsibility starts when you implement that equipment. We don't then just say, well, the patient's got the equipment, and I know, gosh, I know in practice how stretched and under pressure we are. But it is so important that is addressed, and if it means that, you know, when we had that facility where we had we call equipment officer reviewing, the community staff were absolutely delighted that pressure was taken off them, that they did see the importance. They knew that they had to reassess their patients and review equipment, but they just didn't have capacity, and I'm sure that's the same in other areas. So it may be that you look at the model again with your equipment service providers, not just the clinicians, and say, let's invest in this person or persons, because that actually saved our organisation a great deal of money, because we weren't purchasing equipment that we got back into service. So it's looking at the model differently, isn't it? And how we can support our staff to make those reassessments.
Yeah,
but I think
that whole journey, isn't it?
Yeah.
Thank you very much. Moving on, next question, Nikki, for you from Kath. Thank you, Kath. Can pressure cushions be covered as patients report slipping off them and feel the need to cover them with a sheet or a pillowcase?
Yeah, so I mean, we did touch on this in the presentation, but we have done testing in our organisation looking at the interface pressures with covers on there, and obviously they do interfere with the pressure relieving properties of that equipment because they're not designed to have covers on there. I mean, really it's looking at the other issues with the patient. Do they need some kind of continence products or some other kind of products to deal with the particular problem that they have, instead of covering the surface with an additional cover, because it will interfere with that pressure relief.
Brilliant, thank you. So question 5, Nikki again, this is from Amber. How often should pressure relieving equipment be assessed?
Well, again, we've touched on it, but it's really around that when the changes in the patient's condition occur. I mean, it's different in acute and community as to what can be provided, and depends on what level of service cover that you have. So we try and recheck ours, you know, at different touch points on the patient's journey. And it depends on what's happening within that ward or the routine as well. So quite often our wards reassess every week. But if the patient goes to theatre, they might and has surgery, they might need a different piece of equipment, definitely prior to discharge, and obviously depending on their risk assessment and their pressure ulcer if they do have one. But it's all of those different touch points within that patient journey.
Thank you.
I think for me, if I could just add to that, Ed, is totally agree with Nikki. In the community, for me as well, is important areas where with that review and risk assessment is, I've seen it sometimes when the patient's environment has changed. So the patient's conditions remain the same, that no higher risk factors there, etc. But for example, I'll give you an example, a patient who had a private care and the private carer went off sick. So that 24-hour care package that was in place for that patient, suddenly the risk was higher of skin damage because we couldn't do that, encouraging mobility and skincare. And we had to then match that risk of just the environmental change. So you're right, it's the patient, but it's also if something changes in the environment. And I think we were talking about simple things like a power cut and what piece of equipment you might be using, or a combined piece, so that you've still got pressure relief if you lose power. You have a choice.
Brilliant, thank you, Joy. So next question, Joy, for you. This is from Sophie Roberts. Do the use of pillows seriously disrupt the efficacy of pressure relieving equipment, specifically mattresses?
Oh, Sophie, good question. You're testing us this evening. Pillows are important when you're repositioning, in the sense of if you're looking at 30-degree repositioning and tilts, and time won't let me go into detail on that. So we use pillows to position our patients, definitely. We may use pillows, certainly on a ward situation, pillows to offload an area. So pillows aren't discouraged. Again, you've got to be careful that they're used in the correct manner, for the correct reason, and the correct pillow, because I have seen, you know, I'm sure, particularly obviously in in patients' homes, some of those cushions or pillows are extremely hard, and actually maybe too soft, and they don't allow to assist with that 30-degree repositioning or offloading of the heel. And I'm with Nikki on this, irrelevant of what pressure relieving equipment, when it comes to heels, I'm a big believer in offloading pressure on heels completely. And pillows can help there, especially if we haven't got any specific heel pressure relieving equipment in place at the time. So Sophie, we do use pillows, but again, it's follow your local guidance on the repositioning and the use of those and what type. But yeah.
Thanks, Joy. So next question, Nikki, for you, from Stacey Robinson. What are the appropriate pathways when selecting equipment?
Okay, well, thank you, Stacey. Really good question. It depends on what you've got really, and what pathways you've got and what equipment you use, and staff, education and knowledge. However, if you've got that guidance there, then that can really help to make things more appropriate within your selection.
Joy, your thoughts on that? Because I know Nikki.
Yeah, I agree, and I know I keep saying that saying, don't reinvent the wheel. There's really good companies. I mean, IQ Inclusive, who will support you with the development of your own local pathways. Don't because we haven't. None of us have got time, have we? And at least, but just ensuring your pathways are based on the evidence. That goes without saying, but please, you look at other areas that might have implemented a pathway, ask for use of, adapt, but certainly, whoever you purchase or rent or your equipment comes from, use the company. I say use, that's terrible. Work with the companies because they have the evidence, they have the knowledge, and they will gladly assist you in and not just implementing pathways, but the training. Because to me, you cannot beat equipment training other than seeing it in use, appropriate use, whether that be videos. We can't do face-to-face at the moment, but I know in Shropshire our equipment teams were fantastic. You were to have face-to-face, use the equipment, know how to use it. But now we've got fantastic videos and things like that. So that goes in hand with your pathways.
Thanks both. So next question, Nikki, for you again, from Genevieve O'Connor. Thank you, Genevieve. In an acute setting where we get confused patients with pressure sores using a high-low bed, is it suitable to use an air mattress? And if so, why?
Well, again, I think it's guidance upon local policies. In my trust, we've got a falls nurse, and obviously those falls risk assessments that take place. We've interestingly just been looking at developing a pathway where we nurse patients on the floor, which is quite an old-fashioned view and used to happen years ago, but there is a need for that sometimes, although obviously that has to be in the patient's best interest. But I think you need to consider weighing up the risks of everything. So whether what is the highest risk? Is your patient likely to fall, or do they need that pressure relief? And it's getting the input from all those specialist teams as to what your patient's best interest is going to be. And also we'd involve moving and handling teams and safety sides. And it depends what bed you're using as to, measuring. There is national guidance on the depth between the safety sides and the height of the mattress as well. Brilliant,
thank you. Next question for Joy. I hear people talk about active, reactive, and combined systems. Please, can you explain the difference?
Did you have a name who asked that question? Yeah, no, it doesn't matter. Yeah, and I think, I'm glad you've asked that question, because I think a lot of the confusion is around the terminology. I think people do understand equipment, but I get confused on different terminology. So if we talk about reactive, how can I put it simply? And I do want to put it simply, because I think that's where problems stem sometimes, as we get too technical. But reactive tends to be the non-powered, and do bear with me, I'm a bit thirsty at the moment. Foam, air, gel, so they're non-powered. The patient tends to conform in, or I hate the word sinks, but conforms nicely into that surface. it increases the area in contact with the patient's skin or surface and spreads the pressure then along over a wider area. So the non-powered, and that's how they tend to assist with pressure relief. Now the active, so that's your reactive. The active tend to be they are powered. They tend to be more for your high-risk patients, and those patients where repositioning or the patient's repositioning is very difficult or very challenging. Again, they're powered, so we have a surface that's got air cells in, and what they do is they inflate and deflate periodically. So how you set it dependent on the patient's risk factors or risk scores, and then obviously it changes the areas of the body under pressure. But we're so fortunate now that so one's an active, one's a reactive, but now you can get a combined system. So you can have the luxury of a system without a pump, a system with a pump, and you just generally just connect it up with connecting the pump itself. The pumps can be interchangeable from the mattress, from say the pump connected to the mattress or connected to a seat cushion. So there's your 24-hour. With just one pump, so that to me is an advantage as well. You've got that 24-hour pressure relief, and you've got options. And then just simple practical tips, practical things about that is if you do get a power cut, you've got the added reassurance that you've still got a reactive surface, and also to me, when we talked about reassessment and stepping up and stepping down, what a valuable way we can do that without having to move the patient out of the bed, change over mattresses, wait for one mattress to be delivered and another to be collected. This system, we can just connect the pump and we can step up, step down easily. So hopefully I've explained that.
No, brilliant. Thank you, Joy. So on to our last question. Incredibly, the hour's gone. So Nikki, for you, are there any specific cleaning regimens in light of the current climate?
Well, thank you, Ed. That's an interesting question. I think obviously in these COVID times that we're in, we need to be extra vigilant with making sure the equipment's cleaned safely and ready for sort of reuse. So we obviously need to follow local guidelines and manufacturers' guidelines, and also look at your local infection control policies. In my organisation, we're lucky enough to have an equipment store. So once we're finished with our equipment on the wards would wipe them down or demist them, if you like, get a mister in the room, like a bit of a bomb going off, which coats all the systems. And then it's important to ensure the equipment's dried and deflated, rolled up, and then bagged up and labelled. And ours then goes off to the company to be thoroughly decontaminated before it's brought back for reuse. But I think the most important thing is just to follow your local infection control guidelines.
Brilliant. Thank you, guys. And thank you, everyone, for joining us. I thought the event was absolutely brilliant, Nikki, Joy. So thank you. And I can see by the comments and some incredibly kind comments that you agree with me. The certificate for attendance is now available for download. That counts towards your revalidation portfolio. So click on the links that we're providing now on the screen and in the comments bar. And that concludes tonight's event. For more information, to see the event again, go to our website, woundcare-today.com. A massive thank you to you two for giving up your evening and all the preparation you put into it. So a big thank you from me and the team. To IQ Medical, as I said before, these events wouldn't happen without you. So thank you for your support and guidance over the last few weeks and months. And to my team at Wound Care Today and Mole Digital, thank you everyone for a fantastic night. And lastly, to you guys for joining with us, for bearing with a bit of technology problems. Have a lovely evening. Stay safe, stay strong, and we'll see you very soon. Thank you so much.
Thank you.
Bye.